So I just want to walk through now the input screens to the calculator in the slide form, and then, as I said, we will look at a hypothetical scenario, walk through entering the data together, and then looking at the results. So the first major set of inputs when you open up the calculator is the initial fracture, and this is sort of the caseload, if you will, for the FLS program at a given organization. There are two options for how to enter these data. What you see on the screen here we call the detailed option, and I've listed it first even though it's second in the list there because it's the preferred option. It's the more accurate option. I'm going to jump to the next slide and then come back so we can see the difference. But the simplified option requires that the user input describe their population in terms of demographics and then describe the number of fractures they've treated over the past year at any of the 9 fracture sites we have listed here. We then take those numbers and estimate expected values for this table under the detailed option, which again we've said is the preferred, which requires that the user input for each demographic category the number of fractures they've treated over the past year. If, for example, you in your organization's FLS program would choose not to include or not to attempt to recruit patients with ankle fractures into the FLS, you could uncheck the box corresponding to ankle here, and the ankle would disappear from this table, and we wouldn't account for ankle fractures when estimating the caseload of the FLS program. The next very simple input is the recruitment rate. One of the main determinants of both costs and revenue is the number of patients that are going to be a part of the FLS program at an organization. We've heard from a number of folks who are involved with FLS programs and that have been in communication with the NBHA that 80% is a good initial target. However, this parameter, like all parameters in this calculator, can be customized. So if you would hope to aim for a higher target right off the bat or a lower target, you can modify this parameter as you see fit. The next set of inputs has to do with the costs, and there are 2 screens here. This part is looking at the FLS coordinator, which is the person sort of responsible for day-to-day operations and interfacing with patients and coordinating care of patients recruited to the FLS program. Based on the caseload that's entered, the calculator estimates an estimated staffing need for the FLS program. In this case, we've entered 400 fractures, and the calculator suggests that half an FTE will be needed to oversee the FLS program in terms of an FLS coordinator. This parameter can be used as estimated, or it can be modified by the user if you feel like you can, if you need more support for your FLS, or if you can manage with less support. The user then would specify the staff type. The options we have are physician's assistant, registered nurse, and nurse practitioner, which are the common staff types that have managed FLS programs in the past. When you select a staff type, a default salary value from the BLS data will appear here, as well as our default fringe benefit rate of 30%. Both of these parameters can be modified if you have local data suggesting that your staff costs are higher or lower than the default value. The next slide is everything else, all of the other costs associated with the FLS, and this is very much a blank slate. It breaks down costs in terms of labor and non-labor and allows you to enter different staff that are whose costs are attributable to the FLS program in whole or in part, and we'll look at an example of that when we get to the hypothetical scenario. It also allows non-labor resources such as supplies and materials, space costs, or equipment, such as if the purchase of a DEXA scanner is determined to be fully attributable to the FLS program, you can include that here as well. It is very fully customizable for the user to enter whatever the costs are that they face in getting an FLS program off the ground. Finally, this section allows for an overhead rate, which can be applied either to labor only or all costs, and that can be input as a percentage into that box right next to overhead rate right here. The next set of input speaks to the protocol, which is a direct determinant of the revenue generated by the program. We have what we've done with the protocol is split it into a base protocol and sort of an add-on services or additional procedures and services section, which we'll look at on the next slide. The base protocol is composed of the office visits with the FLS coordinator. And so what the user would do here is enter their zip code and select their reimbursement schedule, and our calculator has 4 default reimbursement schedules, 2 for facilities and 2 for non-facilities, each at 100% and 85% of the physician's reimbursement schedule, or the physician fee schedule. So the user would enter their zip code, select their reimbursement schedule, and hit import protocol, and that information will be populated down here. Now, again, just as with all of the other parameters in the calculator, if this doesn't fit the protocol that you've laid out at your site, these parameters, these rows and columns can be modified as you see fit. So if every 6 months, you have one every 3 months, you can add additional office visits or subtract office visits or add other completely different items to this list. It's just the defaults are limited to these types of things for the base protocol. The next screen, as I said, is that are offered, that are made available to FLS patients. Again, the user would enter their zip code. They would select a service from this portion, from this box here, and the services included here include office visiting services, laboratory procedures, physical therapy services, and there are a few others. And when we get to the calculator itself, we'll look at it. Unfortunately, the drop-down doesn't work. But you select your procedure and your reimbursement schedule and hit import procedure. Populates the first row here. You edit as you see fit, and you have your full protocol between the base protocol and the additional services, representing the services that FLS patients get that lead directly to revenue generated by the FLS program. The final set of inputs is the FLS impact. We talked about that when we were going through the slides. The 2 options that we have are this one, which are direct estimates of fractures prevented, where based on the initial fractures that you enter and the models that we've run that underlie the calculator, the calculator will estimate the total number of fractures expected at each site. So say, for example, you expect 100 ankle fractures over the next 2 years. By entering 2.2 in this field, you're saying that you expect that 2.2% of those 100 fractures will be avoided if an FLS is implemented at your site. So that's the interpretation of these parameters. The other FLS impact is to base it on common treatment options, where you would specify the percentage of FLS and non-FLS patients that receive treatment options, whether it be optimal supplementation or pharmacological treatments. The limitation here, obviously, is that it doesn't take into account other things like more prompt imaging or physical therapy may also help a patient avoid subsequent fractures, which is what, although it is prefer that the direct estimates be used to get the best outcome. Jump over to the calculator, and we'll look at a sample scenario of a hospital-based FLS program with 400 fractures in the past year, and we'll stick with the 80% default recruitment rate into the FLS. In terms of costs, this program is staffed by a nurse practitioner as the FLS coordinator at 1/2 FTE. There's also an administrative assistant at 1/4 FTE, with space costs and supplies and materials costs, and on other costs, on total costs. In terms of the protocol, they use the base protocol at the 85% fee schedule at the facility rates, and then they could conduct additional labs and physical therapy respectively, and we'll go through how to enter that into the calculator. Finally, the assumption in terms of impact is that is by between 2 and 8% by site. So I'm going to jump now to the calculator, and we will walk through the input really quickly, and then we'll have plenty of time left for question and answer. The first option is just to enter a name. So we'll just call it sample hospital. And then, as you saw on the slide, we went through the different options for inputting initial fracture data. Normally, when you download this calculator from the NBHA website, this will be blank. However, at this point, I've entered in 400 fractures. You see the sum was 400, so you all didn't have to sit and watch me enter numbers here for 5 minutes to make sure they added up to the right amount. As I said, you could also choose the simplified option where you would fill in demographic characteristics and total fractures by site. But we're going to go with the detailed option here. As I said, we'll stick with the default, excuse me, 80% recruitment rate for the FLS in this sample scenario. We said the FLS program was staffed with at 50% FTE, which is the default, which is the estimate made by the calculator based on the 400 fractures. The calculator does suggest an estimated half full-time equivalent to support the FLS coordinator. However, as I said, if you wish to use a different value, you can simply update this parameter to whatever you would like, and it will modify the staff cost accordingly. But as I said, we will stick with the default estimate of 0.5. Now, as I said, when you choose a staff type, a salary estimate based on BLS data appears here. The nurse practitioner, the national average, 101,000, and we will use a default 30% fringe rate. In terms of other costs, we did have on the slide, we were going to have an administrative assistant at a quarter FTE at a salary of $35,000, and we will use the same fringe rate of 30%. We said that we had space costs at $1,000 and supplies, materials at $3,500, and we said that there would be a 15% overhead rate applied to total costs. So that's how all of that is entered into the calculator. In terms of the protocol, we said that we were going to use a 85%. The FLS coordinator is an NP at the facility rate, so we'll hit import protocol. As I said, you can freely edit these fields as much as you want. You just need to specify all of these different options so that the calculation did. But just to drive home the point that although we have these default values in here, you are not beholden to stick to them. You're free to use whatever most closely represents your protocol that you hope to implement at your organization. The additional services here, we can see I've already entered, I said on the slide there were going to be some labs and some physical therapy services at 3 and 6 months respectively. I've gone ahead and entered some, but just to show, you're going to enter the zip code, you select a service. Let's say we wanted to add a DEXA scan to this protocol at the selected reimbursement schedule. You hit import protocol or import procedure. It gets added to the list. Let's have to fill in the timing of the expected timing of the service. Maybe the DEXA scan happens right away. And the percentage of FLS patients that use that service. And the reason we ask for this information is that we're interested in incremental revenue generated by the FLS. We can't attribute all revenue to the FLS. We have to capture the additional revenue. Just like we wouldn't attribute all costs to the FLS, we can't attribute all revenue to the FLS. So we might say, for example, that 100% of FLS patients get a DEXA, while 25% of non-FLS patients get a DEXA, sort of reflecting the care gap that we saw on the first slide. Okay, and the last set of info that I said on the slide, we were going to assume that the fracture prevention rate, 8% depending on the fracture site. I'm just going to enter some values in here. And I will show you the alternative way that we can account for impact, which you saw in the slides, which is to, again, input it with these four treatment options, which you estimated fracture reduction rates associated with them. And that's it for the data entry. We now have a report. It's ready, done already. I've actually saved this report to a PDF, which is what this button here does. So and we'll sort of walk through the report together, look at the output, and then we will get to any questions that you all may have. The report deals with the inputs. It just sort of summarizes the inputs that you put in. Fracture input procedure. We input 400 fractures at a recruitment rate of 80%. We had our nurse staffing. We also had an administrative assistant. Non-labor costs included space and supplies and materials. On the 400 patients and the 80% recruitment rate, we had 320 patients recruited into FLS. We used the base protocol physician fee schedule in a facility, and we used a direct estimates for our FLS impact data. This over here describes the patient population in terms of the second panel of the report, deals with costs and revenue. So the FLS coordinator salary, after taking into account how many FTEs, their salary, and the fringe rate, comes to almost $66,000. Other labor costs and non-labor costs are added up to get a total cost of $93,000 for the course of the year. Revenue, each patient is expected to generate $752 over the course of 4 years. For 1 year, the entire program generates $188,000. When you compare the total cost to the incremental revenue, you get a return on investment of for every dollar invested into the FLS hypothetical scenario input. Return on investment to the FLS program. The FLS program can be expected to generate $1 in additional revenue. The report then speaks to patient outcomes in terms of fracture frequency. So by site and by year, we can look at the fractures that would be expected with without the FLS, with the FLS, and then the numbers of fractures prevented. So, for example, if we look down here in the lower right-hand corner, we see that without FLS, in the initial population of 400 patients with fractures, without an FLS, we would expect 78 additional fractures over 4 years. But with the FLS and with the impact estimates that we input into the calculator, we would expect 3.65 of those fractures to be avoided. So down to 4.5 fractures. Finally, the fracture cost outcomes describes the total cost associated with the fractures and the savings so we see after 4 years, the total fracture cost is nearing $4 million. However, with an FLS, I have to save about $185,000 in terms of costs of treating those fractures. The final 2 pages of this report are just there to copy over the protocol information because it is so pivotal to the values in the first 2 pages of the report. We wanted to include it so that it didn't get lost on the input screen. So this is just a copy of the information we entered into the protocol screen. So that is the report generated, and it's identical to the report tab on the Excel file. It's just nicer and easier to work with a PDF file, I think, instead of a version.